There's another person coming. Okay, so I am very happy to welcome you today to Mirowitz Center. We're going to talk about colorectal cancers. And did you know that they are the third most common cancer diagnosed in both men and women each year, which is why it is so important that we talk about colon cancer prevention today. It's an important topic. Today's program is co-sponsored by St. Louis Men's Group Against Cancer, and our expert speaker is Dr. Jean Wang. Jean Wang is a gastroenterology physician at Siteman Cancer Center, Washington University, and Barnes Jewish Hospital. She completed her college and medical school education at Brown University, her internal medicine and residency in gastroenterology fellowship at Johns Hopkins Hospital, and was on the faculty at Johns Hopkins Hospital for 5 years before coming to Washington University in 2009. She serves on the National American College of Gastroenterology Patient Care Committee and co-founded and served as chair of the Missouri Colorectal Cancer Roundtable. And that is a resume that should make us all feel like slackers. Dr. Wang is so distinguished, and we are pleased to have you here today to teach us about colon cancer prevention. And without further ado, I will turn things over to Dr. Wang.
Well, thank you so much. It's great to be here with all of you this morning. Let me just share my slides. All right. So we're going to be talking about colon cancer prevention. I'll give you some background information about colon and rectal cancer, and then ways that you can prevent yourself from getting colon or rectal cancer. So let's start out first with the basics. Where is the colon? You know, the colon is the very last part of the gastrointestinal tract where stool exits before when you have a bowel movement. And let me just show you a video that I have here about the gastrointestinal system here. So. All right, so here we see the gastrointestinal system, and here's the mouth here. And when you eat food, you use your mouth and your teeth to grind up the food, as you know. And the saliva is produced by the salivary glands to help lubricate the area and the food. And then it moves into the pharynx and the esophagus. So you can see here, there's a flap here called the epiglottis, which prevents the food from entering into the airway. And so it directs the food into the esophagus. And then the esophagus is a long, narrow tube that has muscles all along it. And the muscles contract to push the food down the esophagus and then into the stomach. So the stomach is this bean-shaped organ here. And in the stomach, there's a lot of acid that's produced by the stomach, which helps to digest the food. And in addition, the stomach is made up of a lot of muscular muscles which contract and break up the food into small particles. And so by the time the food leaves the stomach, it's more of a liquid type consistency. So then it passes out of the stomach and into the small intestine. And the function of the small intestine is to absorb nutrients. And so that's where all the vitamins are absorbed and all the nutrition is absorbed from the food. The liver and the pancreas join into the small intestine and help to secrete bile and pancreatic enzymes, which help to digest the food as well. After it goes through the small intestine, it then moves into the colon, which is that last part of the gastrointestinal tract. And by the time it moves into the colon, it's now waste because all of the nutrients have been absorbed from the food. And so the main function of the colon is to absorb all the extra liquid that remains. And so then, after all the extra liquid is absorbed, then that's when it exits the body as a bowel movement. Okay, so let me get back to my slides. So as we mentioned earlier, the colon cancer is the third most common cancer in the United States. It's every year about 150,000 people get colon or rectal cancer. And it's also the third most common cause of death from cancer. So about 50,000 people each year die from colon and rectal cancer. So it's a very, very common cancer. And chances are that you probably know someone who has had colon cancer. What is your individual chance of getting colon cancer? Well, it's estimated that 1 out of 20 people will get colon cancer at some point during their lifetime. The major risk factors are increasing age. Your risk of cancer increases as you get older, as with many cancers, colon cancer included. If you have a family history or a personal history of colon cancer, or if you have a family or a personal history of polyps, precancerous polyps, that also increases your risk. If you have an inflammatory bowel disease like Crohn's disease or ulcerative colitis, that also will increase your risk. African American race and obesity. So some of these factors are things that you can control, and other things are out of your control. And we'll talk about things that you can do which are under your control that you can to prevent colon cancer in the future. Now, one of the misconceptions is that only people with a family history of colon cancer will get are at risk for the cancer, but that's absolutely not true in the case of colon cancer. By far, the vast majority of patients who get colon cancer are the first ones in their family to have this type of cancer. And so you can see there in the pie chart, 65 to 85% of new colon cancer cases have no family history. Really, those out of all the patients with colon cancer, only 10 to 30% have a family history of colon cancer. And then the rest of the patients with colon cancer have these rare hereditary syndromes that increase their risk. What are the symptoms of colon cancer that you should be aware of? One of the most common ones is rectal bleeding or blood in the stool. And this is very important to not dismiss. I see many patients who say, oh, I've got some rectal bleeding, but it's just my hemorrhoids, nothing to worry about. Well, it's true that hemorrhoids can also cause rectal bleeding, and it is probably the most common cause of rectal bleeding, but it's always important, if you do notice blood in the stool, that you at least get one colonoscopy for further evaluation, and don't just assume that it's hemorrhoids. Anemia is another common symptom that goes along with the rectal bleeding. If you're losing blood in the stool, then it's going to cause you to have a low blood count. Unintentional weight loss is another common symptom, persistent abdominal pain, and a sudden change in bowel movements, especially new onset of constipation. And this is because colon cancers can cause a partial blockage in the colon, and so it can make it difficult then for a stool to move past the tumor, and so that can cause a new onset of constipation. If you have any of those symptoms at all, make sure that you try to go in to see your doctor and get a colonoscopy as soon as possible for further evaluation. Now, what are the things that you can do to prevent colon cancer? Well, by far, the number one most important thing is to make sure that you get screened for colon cancer. It's one of the best ways to make sure that you can prevent yourself from getting colon cancer or detecting it early when it's still at a curable stage. So what is a screening test? What is cancer screening? It's a test which looks for cancer or precancerous growths before a person has any symptoms. You know, I see many patients who say, well, I'm feeling fine. You know, why, go through this test if I don't have any problems? They think that as long as they're not having any symptoms, that they must be healthy and they don't need to do any further. You know, why fix something that isn't broke? Well, this is a common misconception, and it's really important to still get these cancer screening tests, even if you feel at your best and you're not having any symptoms at all, because precancerous growths and early cancer usually do not cause any symptoms at all. In the colon, the precancerous growths are called polyps. And here's a picture of what a polyp looks like. It's basically a little bump or a growth in the lining of the colon, as you can see there. Now, there's different types of polyps. The two main categories of polyps are hyperplastic and adenomas. So hyperplastic polyps are just extra normal tissue, and they are considered harmless. They do not lead to cancer. The other type of polyp is called an adenoma type polyp, and these are precancerous polyps. So what this means is that at the adenoma stage, at the polyp stage, they are not cancer, they are benign. But if they are not removed, they can keep growing bigger and bigger and eventually turn into a cancer. And that whole process takes about 10 years for a polyp to start out as a tiny little bump and eventually turn into cancer. That takes 10 years. So that's, really good, because it takes so long. That's a great opportunity for us to then detect that growth before it turns into cancer and remove it. So these are, this is what it looks like when a polyp turns into a cancer. So at stage 0, that's what the polyp is called, stage 0. That's not cancer. That's just a polyp, just a growth on the surface lining of the inner lining of the colon. Now, once it, after 10 years, once it turns into a cancer, then it starts growing into the wall of the colon. And at that point, it's called a cancer, and it's stage 1. If it keeps growing bigger and bigger, it's called stage 2. And then by stage 3, that's when it's grown through the entire wall, through the other side, and started to spread, the cancer spread into the nearby lymph nodes. And if it keeps on growing undetected, then it can eventually get to a very large size where you can see it's almost completely blocking the colon here. And so you can see how it can start causing constipation at this point. And not only that, but the cancer has spread through the lymph nodes and into the bloodstream and spread to other organs, for example, the liver. So at that point, it's stage 4 when it's metastatic colon cancer. So again, why is screening so important? It helps us to find cancer at an early stage before symptoms appear. When precancerous growths or cancer are found early, it's a lot easier to treat or cure, because by the time symptoms appear, usually at that point, that's when the tumor is quite large. And oftentimes the cancer has already grown into the wall of the colon, through the wall of the colon and spread to lymph nodes or other organs. And at that point, it makes it much harder to cure. We know that early detection saves lives. You know, if we catch a colon cancer at an early stage, at the local stage when it's just confined to the colon, then it's very easy to treat. Patients can just undergo a surgery to cut out that section of the colon. Then you get reconnected, and the cure rate is 90% in that situation. And oftentimes patients don't have any symptoms after the surgery if it's just a small section of colon removed. So you can keep on, living your life as you were before without much interruption or disruption. Once it's spread to the regional lymph nodes, nearby lymph nodes, then the survival rate drops to 71%, still pretty good. But once it's spread to other organs, distant organs, then it's really a poor prognosis, only a 14% survival rate. These are 5-year survival rates here. So it's estimated that 75% of colorectal cancer is preventable. Of all types of cancer, colorectal cancer is one of the most preventable and curable. That's because we've got tools, screening tests available today that can help prevent colon cancer. That's different from breast cancer and prostate cancer, for example. We have good screening tests for breast and prostate cancer, but we don't actually have screening tests or tools that can remove precancerous growths and therefore prevent cancer. So colorectal cancer is unique in that aspect. Now, what are the current guidelines for screening? So for people at average risk, the average person, it's recommended that everyone start regular colon screening at age 45. And that's a change, a recent change, because it used to be starting at age 50. So about 2 years ago is when the recommended age was lowered, the starting age. So starting at age 45, and then going until age 75, getting screened. Now, from the ages of 76 through 85, it's optional whether you want to continue screening, and you should talk to your primary care physician and go through risks versus benefits of continued screening. By the time you're over age 85, we do not recommend colorectal cancer screening. And that is because the screening tests, the risks of the screening tests do increase as you get older. So unfortunately, we're finding that many people are not up to date with colon cancer screening. Based on recent data, really only 67% of people in the eligible age range are up to date with their colon screenings, whereas 25% have never been screened. Now, this data was collected before the recent lowering of the starting age. This is between age 50 and 75. So it's really a shame that those 25% who are never screened, those are often the patients that are coming in with the colon cancer, and that could have been prevented. Now, what are the options for colon cancer screening? There's actually several different options that you can choose from, and you only have to choose one of these options. And so what I'm talking about here is for people who don't have a family history of colon cancer. So the most common ways to screen are to either get a colonoscopy every 10 years or to do a stool test. And there's several different stool tests available. And these are tests that you can do at home, which I'll go into more detail later on in the talk. But you can either do a stool test that is done once a year, or a stool test that's done every 3 years. And what the stool tests do is they both detect blood in the stool, trace amounts of blood that you might not see with your naked eye. And then one of the stool tests, the Cologuard, also will detect abnormal DNA that might be coming off the tumor in the stool. Now, other options that are less common ways to screen would be CT colonography. This is called also a virtual colonoscopy. And basically, this is a fancy type of CT scan that specifically focuses on the colon it produces a 3-dimensional image, and that's recommended every 5 years, or a flexible sigmoidoscopy every 5 years, and that's a shortened version of the colonoscopy. So you only need to choose one of these options, if you're the average person. Now, if you do have a family history of colon cancer, and when we say family history, we're really talking about close family, first-degree relatives, such as a parent, sibling, or child with colon or rectal cancer. If you fall into this category, then your chances of getting colon cancer are higher than the average person, 2 to 4 times higher, in fact, but still nearly completely preventable. So in this case, we do recommend colonoscopy every 5 years, and we also recommend starting earlier than age 45. In most cases, we recommend starting at age 40 or at least 10 years before your relative was diagnosed. So if you had a relative diagnosed at age 45 with colon cancer, then you would have to start at age 35. And if you have a family history of colon cancer, we only recommend the colonoscopy as the screening option, not the stool testing, just because colonoscopy is considered the gold standard and the best test for screening. With colonoscopy, what we're doing is we're using a long tube that has a camera on the tip of it, and it also has a light source, and it basically allows us to look inside the colon with a video camera, and you can see what it looks like there. And so since we're looking directly inside the colon, this is considered the gold standard. The stool testing that I mentioned before, there are 2 different types that you do once a year. And one is called the fecal occult blood test, and the other is called the fecal immunochemical test, which is a newer version. These are at-home stool tests that you can do on your own. And basically, at home, you would, when you're ready to have a bowel movement, you would collect your stool by putting some paper over the toilet there, and then you would take a little stick and scrape off some of that stool, and then put the sample on a card, or sometimes there's a vial that you put the stick into. So you're basically just taking a small sample of your stool and sending it into the lab to check for traces of blood. Now the Cologuard stool DNA test, this one involves sending your entire bowel movement, not just a little sample, but the whole bowel movement into a container there, and you will actually mail your entire bowel movement in a box to the lab. And so they will also be checking for traces of blood in the stool, as well as traces of abnormal DNA that may have come off of the colon cancer. And this is a test that would need to be done every 3 years. Again, these stool tests are for people who don't have a family history of colon cancer. Now, less commonly is the CT colonography. And as I mentioned, this is a 3-dimensional CT scan. And you can see here it produces an image of the inside of the colon similar to the colonoscopy view. You can see a little polyp here at the bottom of the screen. So this is pretty good at detecting large polyps, but not so good at detecting smaller polyps. The advantage of this test is that you don't have to be sedated for it like you do with the colonoscopy, so you're awake the whole time. The disadvantage is that there is some radiation exposure from the CT scan, and also you're not able to detect these smaller polyps. A flexible sigmoidoscopy is a less common option for screening. This is basically a shortened version of the colonoscopy. So we use the same kind of instrument, long tube with the camera, but we're only going in the lower 1/3 of the colon. So you're not seeing the entire colon. And you can do this test while the patient is awake. So that's the advantage of this test. But now that colonoscopy is available, by far most people choose colonoscopy over sigmoidoscopy, just because the colonoscopy is a more complete test, allows you to see the entire colon. So this is just a summary slide which goes over all of the screening tests that I just reviewed. And I put stars next to the most common tests that are used in the United States: colonoscopy, the fecal immunochemical test, or the multi-target stool DNA, or Cologuard. Now, if you don't choose one of the colonoscopy option, if you choose one of the stool tests or the CT colonography, then it's important to realize that if any of those tests come back abnormal, then you will need a follow-up colonoscopy. So what does a normal colon look like? Here's a picture of, nice normal colon. You can see there's no bumps or growths in there. Nice flat surface. Now, what do polyps look like? Here you can see the polyps appear as these bumps inside the lining of the colon here. And on the right side is what a cancer looks like. So you can see it. It's really abnormal looking. It's almost completely encircling the inside of the colon there and causing a narrowing. So it's very obvious, usually with the colonoscopy, when we come across a cancer. And when we run into polyps, how do we remove them? The great thing is with colonoscopy, right then and there while we're doing the test, if we run into a polyp, we can remove it. And by doing so, we can then prevent that patient from getting colon cancer in the future. So if it's a smaller polyp, then we use forceps. And this is an instrument that we can put through the entire length of the tube that we use. And it looks basically like tweezers, and we pick off the polyp. If it's a larger polyp that we're not able to pick off like that, then we use an instrument called a snare. And basically what we do is we make a lasso and lasso the base of the polyp there and cut it off just like that. And so that is also a very easy way to remove polyps that are larger. All right, so now let me share this video. All right, so you can see this is an actual colonoscopy that is being done, and you can see there is a large polyp there. And this is a pretty large polyp, so we're not able to remove it with just that tweezer method. We'll have to use a snare method. And here we're looking at the polyp under a different type of lighting, which helps highlight the surface pattern and just helps to highlight the difference between the polyp surface and the normal colon surface. So we can see that it obviously looks different. So what we're going to then proceed to do is to put that wire loop through. It's called a snare. And basically put that loop out, that lasso out. And then we will put that lasso to encircle the base of the polyp. So should be seeing that shortly. And the patient is asleep, during this time when we're doing this, so they don't feel anything at all. So here you can see the lasso, and that's going to be closing in on the base of the polyp there, the bottom of the polyp. And then using little cautery, which is basically some electrical current. It will basically cut off the polyp just like that. So you can see within a few seconds, we've cut off that polyp. And that's a polyp that would have turned into a cancer, within a few years. And so, by that patient making that choice to come in to get the colonoscopy and then being able to get it removed, that patients saved themselves from getting colon cancer in the future. And the whole process took just a few minutes. And that's how easy it is to prevent colon cancer. If that patient had decided, no, I don't want to do a colon screening and, let me just go on and live my life, that polyp would have kept growing and growing and eventually turned into a colon cancer. So, you've seen now what a colonoscopy looks like. And, it's important to also mention that when you get a colonoscopy, it's important to do your part before the test, and that is to do a colon clean out. We need to clean out all the stool in the colon ahead of time so that we can get a good view when we look in with the camera. So, I often tell patients that, doing a colonoscopy on a clean colon is like driving on a nice, clear, sunny day. You can see where you're going and you can see exactly what you need to. Whereas if you don't follow the directions and you don't clean out your colon well enough, then it's like trying to drive through a blizzard and you really can't see things very well. And so it really is to your benefit to clean out your colon as well as possible so that the doctor can get a very good view when they do the colonoscopy. Otherwise, there may be polyps or even cancer hiding underneath that stool there. Now, other than screening, what are other ways that you can prevent yourself from colon cancer? Another important factor is maintaining a healthy weight. We know that obesity has been linked to increased risk of not only colon cancer, but many other cancers as well. So make sure that you're maintaining a healthy weight. And how do you know if you have a healthy weight? So the best way is to use a body mass index calculator. And you can find one by just doing a search for CDC BMI. The CDC has a calculator on their website. And basically, all you have to do is go to that website, plug in your height and your weight. And I've just put an example there. And then it will calculate your body mass index. And so that will be, that here shows that your BMI is 23 in this hypothetical example. And they have categories for what's considered normal BMI versus overweight BMI or obese BMI. So try to, and it'll tell you here what your healthy weight would be for your height. So that would be your target, weight to aim for. Another big important factor is don't smoke. Smoking, not only increases your risk for lung cancer and heart disease, but also colon cancer, as well as many other cancers. So definitely stop smoking if you're currently smoking. That will definitely increase, smoking will increase your risk of colon cancer. Also, try to be physically active. Studies have shown that if you can exercise regularly, and typically this means 30 minutes or more of active exercise a day, then that has been shown to decrease your risk of colon cancer. And again, this is also decreases your risk for many other cancers as well. Drink only moderately, if at all. So try and cut down on your alcohol use. And then finally, try to limit red meat and also processed meats. So studies have shown that diet can also influence your risk. Red meat and then processed meats like deli meats or bacon, any kind of meats that have gone through processing, smoking, or smoked meats, for example, or have preservatives, have been linked to an increased risk. And I would say processed foods in general have been linked to an increased risk of colon cancer. So it's best to try and eat foods in their natural form, you know, fruits, vegetables, meats. I tell people try to shop in the grocery store along the edge of the store. That's usually where all the produce and the meats and fresh foods are, whereas the aisles are where the boxes of processed foods are. Try to avoid those. All right, so any questions about anything that I've said today? I'm happy to take them in the chat box or to answer them. If you want to speak your question as well, you can raise your hand.
This has been very, very helpful. The slides have been very helpful.
Great, I'm glad to hear that.
I have a daughter who's had stage 3 colon cancer. So that makes me at risk too, I guess, doesn't it?
Yes, yes, it does. So you should be getting a colonoscopy as your only option for screening. And you should be getting it every
I'm over 85, so I don't
okay. Okay, well, if you're over 85, then I guess you're past the age where, you know, we would recommend screening. But if you were younger, then we would recommend every 5 years.
Yes, thank you.
So Linda would like to know, are there any special concerns for people on dialysis?
Yeah, so we do procedures on patients on dialysis all the time. For people on hemodialysis, we do try to time it so that it's, you know, in between their dialysis sessions. And so it's typically best to do it, you know, the day after a dialysis session so that your body, you know, doesn't have any extra fluid on board. So I would say, you know, we would aim to do it like the morning after the dialysis day. And then in terms of the bowel preparation, the medication that we give to do the colon cleansing, there's several different options for colon cleansing. And the traditional way that we use to prep is using something called New Lightly or Go Lightly. And that is also the safest bowel preparation for patients on dialysis because it will has the least risk for electrolyte imbalances or fluid shifts. But we do colonoscopy on dialysis patients all the time. But stool testing is also a good option as well if you'd rather not go through trying to time it and so forth.
Any other questions? Dr. Wang, can you explain why do some people naturally have more trouble going to the bathroom than other people? Is there something is that a hereditary thing, or what can we do to work with that?
Yeah, well, constipation is a very common problem that we see in our gastroenterology clinic. And, you know, I think that the most common underlying reason for that is lack of fiber in the diet. There's not been a hereditary component found with constipation, but I think that with the American diet, most people are not eating very much fresh fruits and vegetables. They're eating a lot of processed foods, and they're not getting enough fiber in the diet. The recommended amount of fiber is 25 grams of fiber per day. And so most people are not getting that. And that is the #1 cause of constipation. So we find that if people just start, you know, eating more vegetables, or taking a fiber supplement, that can help with constipation a lot. Also, another common issue is that many medications have constipation as a side effect. And so that can also be another common cause of constipation, especially in older people. And sometimes you do need to take those medications. There's no way around it. So then we try to treat the constipation, through other methods. We would try the fiber first, increasing the fiber with a fiber supplement. But if that doesn't work, then we would recommend an over-the-counter medication such as Miralax to start with. And if Miralax doesn't work, then there are several options for prescription medications to treat constipation.
Dan would like to know, he says he's 76 and at his last colonoscopy, he was told he wouldn't need to have any more. Should he do anything on his own?
Yeah, so as we mentioned, between the ages of 76 and 85, it's optional whether or not you want to continue colon screening. And that's all dependent on, your current health and weighing the risks versus benefits. I would say that if you are someone who has no heart or lung problems, if you're in very good health, then I would go ahead and continue screening until age 85. If you do have heart and lung issues, or if you have other major medical problems, then I would not recommend continued screening. So, it's really a conversation you should have with your primary care physician as to whether you should continue it, because colonoscopy involves getting put to sleep, oftentimes with anesthesia, and this can be a stress on the heart and lungs. And that's why as you get older, the risks of undergoing colonoscopy increase. And also at the same time, the colon wall just gets more fragile as well. And so there can be a higher risk for a tear or perforation also during the colonoscopy. So those are reasons why, after the age of 75, we say it's optional. So it really depends on what your baseline health is, as far as if you want to continue. But definitely by age 85, we don't recommend it.
Other questions?
And I'm happy to answer any general gastrointestinal questions as well.
Dr. Wang, I'm also curious, if you have a polyp removed, is it more likely that other polyps will grow in that same area? Or once you've had it removed, is it the same risk as any other part of your colon?
Yeah, once you've had a polyp removed, it's the same risk as any other part of the colon. But we do find that people who have a history of polyps tend to grow more polyps in the future. And we don't know why some people tend to grow polyps and other people don't, but it is very common. Out of everyone coming in to get a screening colonoscopy, almost half of those people, we will find polyps in them. And so it's a very common thing. And that's why colon cancer is so common. And, it's, I think, a combination of some of the risk factors that I talked about that are, under your control, but also maybe related to genetic factors as to why some people get polyps and other people don't. But generally, once we remove the polyp completely, it wouldn't grow back in that particular spot, but it may grow back in other areas. And so if we find the adenoma type polyp in you, that's the precancerous type of polyp, then we would have you come back earlier for a repeat colonoscopy. Rather than doing the colonoscopy every 10 years, we might see you back in 5 years or 7 years, just depending on the type of polyp you had, the size of them, and the number of polyps you had. Will make a recommendation when you should come back. But it will be sooner than 10 years because we want to catch those polyps while they're still small and while they're still easy to remove.
Linda would like to know, is there a normal amount of bowel movements? Or should she only worry if her routine changes? That's a great question.
Yeah, that's a common good question. So the normal frequency of bowel movements, there's actually a wide range. You know, a common misconception is people think that they need to have one bowel movement a day, and if they don't, it's abnormal. But that's not true. Actually, a normal frequency of bowel movement can range anywhere from once every 3 days to 3 times a day. And so anywhere in between that range is considered normal.
Just to clarify too, when you were talking about the 2 different types of polyps and that there's non-cancerous polyps and precancerous polyps, will a non-cancerous polyp, if it's not removed, eventually always turn into a precancerous polyp and then cancer?
No, actually, the non-cancerous polyps or the hyperplastic polyps that we mentioned before, those are completely harmless. They are just extra normal tissue. And if they are not removed, they will never cause problems. They will just stay like that, and they will not turn into a cancer. It's only the adenomatous polyps that are considered precancers that could turn into a cancer in the future. And the polyps do look a little bit different, you know, on their surface. And so oftentimes we can tell the difference when we're looking at them with the camera view by looking at the surface pattern, which category of polyp it is. Sometimes if we can't tell the difference, then we'll just remove all the polyps. I mean, I typically will remove all the polyps anyway, and just to be on the safe side, and then send them all to the lab and have the pathologist tell me, you know, which polyps were adenoma type and which polyps were hyperplastic.
Any other questions? Well, this presentation was fantastic, Dr. Wang. It's incredible that you said colon cancer is one of the most preventable and curable cancers, and yet 25% of people don't even get screened. So this is just excellent information. And I loved how you showed what a colonoscopy looks like. You know, we've all had colonoscopies. I think probably this group who's here is more concerned, and that's why we're learning from you. And so now we know what is going on when they do a colonoscopy or when you've had polyps removed. And you've just given us a wealth of good information. I know I already am going to check out the BMI, the CDC BMI calculator, and calculate my own weight and make sure that I do the things I need to do to be healthy and prevent colon cancer. So thank you for being here. Thank you everyone else for joining us today. And we appreciate you sharing your expertise with us.
Thank you very much for having me.
Bye-bye, everybody.
Thank you.